Thank you to everybody for joining today, tuning into this Multiple Myeloma Awareness Month panel. Today, we're doing something a little bit different from our usual content and having a discussion geared towards patients who are living with multiple myeloma. And I'm joined today by our editor-in-chief, Dr. Rahul Banerjee, and as well as our editorial board members, Dr. Gurbakhash Kaur, Dr. Alankrita Taneja, and Dr. Richa Thakur. We have some really exciting updates today in store in light of Multiple Myeloma Awareness Month, and we're excited to cover them today. And we'll also have some time at the end for questions. So if anybody has any comments or questions you'd like to ask our panelists, feel free to type them into the chat on YouTube and we can pivot to those at the end. So without further ado, I will turn it over to our panelists to start the discussion.
Sounds good. Thank you so much, Kiara. I'll just start with introductions. My name is Alankrita Taneja, and I'm a third-year fellow for hematology and oncology at Roswell Park Cancer Institute. I was wondering if all of you could also introduce yourselves.
Sure. Hi, I'm Richa Thakur. I'm a second-year HemOnc fellow at Northwell, and I'm also really interested in hematologic malignancies, and I'll hand it over to Rahul.
Okay. Hi, everyone. My name is Rahul, Dr. Banerjee. Call me Rahul, please, for this podcast. I'm assistant professor of medicine at the Fred Hutchinson Cancer in Seattle, Washington. So I think, well, actually, Dr. Gurbakhash will beat me, but it's 65 right now in Seattle, so we may win weather-wise. We'll see how Dallas is doing.
Hi, everyone. My name is Gurbakhash Kaur. I'm an assistant professor here at UT Southwestern Simmons Cancer Center. My focus is, mostly plasma cell disorders, including amyloidosis and myeloma. And I actually, I've been in clinic all day. I don't think I've even paid attention to the weather. But you might be, you're probably right, Rahul. The weather may be better over there than here today.
So one day of the year where that counts.
Yes.
All right, we're definitely losing for weather in Buffalo because I think I saw some snow. But having said that, Rahul, I'll start with asking you what your approach is for newly diagnosed multiple myeloma patients. I know for the longest time, even when I started my training 3 years ago, we would, bring in the patients, have them evaluated for transplant, over time too, dynamically, and we can talk about that. But our first line treatment used to be a triplet therapy or a combination of 3 drugs. And over time, we saw some studies showing benefit of a quadruplet regimen or 4-drug regimen, starting with the Griffin trial. In my second year of fellowship, we showed that the addition of anti-CD38 daratumumab to the frontline improved responses. And this was followed by some more studies in the last ASH, such as the Pursues trial, which showed a longer duration of treatment, and progression-free survival benefit. So, what is your take for a newly diagnosed multiple myeloma patient in your clinic at this time?
Yeah, absolutely. So, and I'll be curious to hear Gurbaksh's take on this afterwards. So I think, for patients listening to this, as Alankrita just mentioned, so, a triplet is something plus something with dexamethasone, and a quadruplet is something plus something plus something plus dexamethasone. And the question really is that new 4th drug, the new kid on the block, daratumumab or Darzalex or FastPro, it goes by many names, is a targeted therapy that we typically use in later lines of therapy and have increasingly used in the front line, meaning as patient newly diagnosed. There's another version called isatuximab or Sarclisa. Some of you have Kaiser Insurance, for example, on the West Coast may have gotten that instead in coming years. So my bottom line is I prefer for everybody to get a CD38 monoclonal antibody at presentation. That's either daratumumab or Darzalex FastPro or isatuximab Sarclisa. Doesn't matter to me which one, triplet versus quadruplet, we can come back to. I think in the Griffin study, we saw very clear. Griffin was a phase 2 study, which means it was designed to see if adding that drug makes patients get deeper remissions, or get the myeloma numbers down deeper, not necessarily to make them, stay in remission for longer or live longer, for example. And so the Griffin study showed that adding a drug like this, like daratumumab or Darzalex in the frontline setting, got deeper responses. It happened to show that patients actually were in remission for longer, but it wasn't designed to show that. So this bigger study, the Perseus study that got presented at a big meeting in San Diego last December, showed that without a doubt, no statistical qualms or methodologic issues about it, adding a drug like this means that patients are in remission, that they're harder, faster, deeper, stronger is what I tell patients, that they get into remission faster, deeper levels of remission. Some are even MRD negative, meaning we can't see any myeloma there. And importantly, they're in remission for longer, which I think is really, really important. For patients, and that's technically for patients who are supposed to get a transplant, which we'll, I'm sure, come back to as we talk about that. For patients who are not planning to get transplants, there are two commonly used options that are triplets. One is VRD with bortezomib, which is called Velcade, Revlimid, lenalidomide, and Dex, or daratumumab, the drug I just mentioned, plus Revlimid, lenalidomide, or Dex. I tend to use the latter. Again, that same principle as a targeted therapy gets people into remission very quickly. I've had many patients go, their light chains and the M spikes start to come down within a month, which is wonderful to see. But that hasn't been compared in a randomized manner, DRD versus VRD. But certainly, I think the trend in the US is moving towards more people getting daratumumab up front. Gurbakhash, anything you would add?
No, I think I have a very similar approach. Many people are adapting DARA, the 4-drug regimen right now, which is a monoclonal antibody plus the proteasome inhibitor and the IMiD now. But I think we sort of started doing that roughly 3 years ago. So sort of for all comers, they used to be that you reserve this regimen for the high-risk patients, the patients whose the genetics of their cancer of the plasma cells, such as translocation 414, GAIN1Q, or TP53 deletion, findings like that. Those patients ended up getting a quadruplet therapy. But I think now sort of the standard is that everybody gets a quadruplet. And I think, Rahul, I was going to add to this. Many people question, like, why are we giving all the big guns up front, right? Why are we not saving some of this stuff for later? But I think we have to keep in mind that there's a very high attrition rate. There was a retrospective study done a few years ago that showed that with each subsequent therapy, we lose about 15 to 30% of patients. So we want to capture all of them and we want to keep those patients in remission. So 15 to 30% of patients don't make it to the next line of therapy. So we do want to give them the big guns in a safe and effective manner up front. So I think that's what I'd like to add. And I agree with you that the trend in the US is that for the transplant ineligible patients, we are doing more of the Maya regimen, which is the DRD versus the SWOG 077 regimen, which is VRD. I agree with you on those. So my practice is very similar.
Agreed. And then one other thing I'll add to piggyback on Gurbaksh's point that came up at ASH, there were a lot of talks around dynamic frailty, which means that patients actually get better with treatment. Right? Many of you listening to this, you may remember a time when you were diagnosed when you probably assumed that, all right, as soon as our therapy, I'm going to feel worse. And that's very reasonable. And I often counsel patients, you may start to feel worse. You may have a rash with the lenalidomide. The Dex is going to make you feel miserable, et cetera, et cetera. But I think there was 2 oral abstracts, or at least one at this big meeting last December, that showed that, especially with these modern therapies that Gurbaksh is alluding to, that patients get into remission faster. And that's not just numbers on a page. That's the patient's feeling better, walking more, their pain is better controlled, no longer need to use a walker. And that's wonderful. And what they actually found was that for those patients with dynamic frailty, I don't love the word frail, but it's important to note that in the medical field, we're not using it as a binary, like, oh, you're frail or you're not. It's a kind of a whole grades of, different ways of looking at how fit people feel, how physically able they are to function, that one's destination level of frailty is a better predictor of how one does than one's original frailty. So meaning that for patients who were diagnosed and felt really crummy, weren't able to get much treatment, barely able to walk, and got a regimen like daratumumab and all of a sudden felt more fit, less frail, they do just as well as those patients who were had that level of fitness all along. And I think that's another example, to use our big guns, so to speak, earlier, is that they get people into remission faster and that gets them feeling better. And that's better both for that line of treatment and, as Dr. Kaur alluded to, in future lines of therapy, that's helpful.
I think one other benefit of daratumumab we also often overlook is it's given as a subcutaneous injection as opposed to an infusion. So at least in our clinic, the number one thing I always hear patients complain about is just the long wait times of having to sit in the chemo chairs. So at least to get their chemotherapy. So at least an injection that you can get in a couple of minutes, it doesn't really add much more time for the patient to be sitting and waiting for treatment, but so much more like improvement in efficacy too for their disease control.
Definitely. From my experience, I've seen patients tolerate it really well too, as compared to some of the other therapies. So, very exciting information about attrition. And, I would just like to elaborate on what we mean by that. So you mean, Dr. Kaur, is that patients just, are lost to follow up in the further lines of treatment?
No, I think they just they succumb to the disease or they have toxicity and they don't make it to the next line of therapy. So this concept of saving the best till the last doesn't hold true in that setting. So you want to get there's a balance between safety, how safe the drugs are, and the efficacy, the effectiveness of the medication. So you do want to give your best drugs upfront in order to make sure that patients stay in remission longer.
And I'll add one level to that I think, and Gurbaksh, you told me if you've heard the same thing. Many of my patients, when they were diagnosed, there was this belief 10 years ago. At the time, it was correct that every medication had a shelf life. As soon as someone had gotten bortezomib or Velcade, and the myeloma started to grow despite it, they were refractory to the Velcade, the bortezomib, they could never get it again. And people, at that point, that kind of made sense in some way or form. Now, as patients are living longer and longer with myeloma, I routinely recycle old therapies again. So just because someone got daratumumab now, for example, doesn't mean they can never get it. Let's say they get daratumumab now, they get a transplant or don't, and end up on lenalidomide, Revlimid maintenance for years, and then the myeloma decides to creep back up again. I can very easily give them daratumumab then. I've had some patients, we'll come back to CAR T, I'm sure, in the second half of this podcast, which has also had a lot of updates both at ASH and last week. 5 days ago, less than that, 3 days ago, had a lot of big updates in the myeloma field. But I've had patients where the CAR T stops working, right? So 3 years after CAR T, now they're having the myeloma numbers come back up again. And I give them that same daratumumab from years ago, and it works like that because the myeloma cells have forgotten about it. So I think it's the other, people sometimes get nervous about using the big guns because like, what'll we have 5 years from now? 5 years from now, I hope we'll have better options regardless for patients with myeloma. But 2, very reasonable to recycle some of these medications.
Yeah, and I think theoretical and practical are 2 different things, right? In theory, we cannot recycle them, but in practically, oftentimes we read the clinical trials that say the median prior lines of therapy were 7 or 8. And that just means how many different regimens patients got, and each time their myeloma relapsed. And oftentimes in between those regimens is recirculation of older drugs, right? So we end up recirculating drugs. And even by today's standards, we're talking about CAR T. And maybe I'm going to jump into this early now, and I don't know if I should save this for later. But it's the drive on point is that why is there a need to even have CAR T moved up earlier? Because there's a gap where we don't have effective options between second and fifth line of therapy, right? Because we end up using many of these medications. So in those, where we have a gap, we recirculate a lot of the older drugs, as Rahul alluded to.
And theoretically, I believe that there was also a concern, regarding the CD38 antibodies, that the CD38 receptor, which is on the cell on which these drugs act, apart from other mechanisms, especially for DARA, they could be downregulated or they could be removed from the surface, and subsequent therapy with the same drug would not act. And maybe some other CD38, like isatuximab, would act. But maybe some studies, also did not show that there was any problems with repeating daratumumab. So what is your take on that?
I can go. I think there's, exposure and refractoriness are 2 different things. You could be when somebody gets daratumumab up front, and then, like Rahul said, undergoes a stem cell transplant and then is on Revlimid, means they're daratumumab exposed. They're not necessarily, their myeloma didn't stop responding to it. And it didn't, the removal of daratumumab from the treatment plan wasn't because there was some sort of resistance mechanism. So exposure and refractoriness, I think, are 2 concepts that we often as oncologists discuss. So if somebody's just has an exposure to a drug and there's a break for some reason, whether the patient prefers to have a treatment holiday or because they went on to have a different treatment plan, you can recirculate that. Now, if they're truly refractory, you can always reuse it. We use it in combinations because it'll provide synergy, meaning two drugs working very collectively will deepen each other's response. By itself, you might be a little bit hesitant about. So I think we have to sort of talk about that.
Okay, I think we have a question from the audience. How long typically do you stay in remission after being on Darzalex for 1 year and a half? 11 years ago was the diagnosis, has had various treatments, and the longest remission has been a little over 2 years.
I can take that one. So it's an excellent question, Kathy. Thank you for sharing that, and thank you for you passed 10 years and now 11 years now living with myeloma, which is wonderful to hear. It is true that over time, I often find that each individual line of therapy doesn't seem to last as long as it might have before. So for a patient newly diagnosed getting daratumumab today, for example, in the Maya study, so even if you take up transplant and just give Dara Rev-Dex, Dara lenalidomide index, on average, I typically tell patients about 5 years of mileage out of that. As the myeloma has been around for longer and longer, the cells start to get a little bit wilier and wilier. And so here, I would say that probably, like 2 to 3 years, I think is very reasonable, depending on your medical situation and what you've gotten. For example, this would be a scenario where I do think newer therapies like CAR T therapy, bispecific antibodies, there'll be a newer version of lenalidomide or a newer version of pomalidomide, I should say, or both really, called CELMoDs that should be hopefully approved this year. That might be really nice. So this would be a scenario where these newer therapies may actually end up having the most mileage, but the existing therapies do have some role, especially as they're hoping to keep disease control while we wait for something new to emerge.
And I think one more thing we should probably talk about with just like general paradigms for treating myeloma is usually we started with doublets like decades ago, and then we've transferred to triplets and quadruplets as the better, bigger guns are moving frontline. Meaning all of the new drugs we usually give after patients have tried multiple lines, but the better they do, the earlier we bring them to the treatment timeline for patients. But the thing is, as we do this, it's also really difficult to know how each of the newer drugs will respond in a different sequence too. And especially with myeloma, most of the treatments we have today, it's really to get better disease control. It's not necessarily to cure, although with like such great improvements with BiTEs and CAR T, I really think a cure is on the horizon, like very soon. So when we're really focused on trying to make sure that we keep patients with symptoms very well controlled and keep their disease controlled for much longer, what like our bigger take-home point is not necessarily we're worried about overall survival. It's really quality of life, symptom control, and getting the best bang for our bucks as we can. And so each of these new trials that we come out, and we keep changing the order of how we give different treatments to patients, is to see how can we do this better than we've done it in the past. And so especially nowadays, what a patient would get coming in today isn't what a patient would have gotten even 1 to 2 years ago. So, and this is probably true like everywhere in cancer, just because the research is so rapidly evolving.
I completely agreed. And I will just add to the Rich's point that, we're constantly making newer therapies that work better, not just in terms of efficacy, but also, better safety. And, one topic that'll come back again and again is this word that I like calling it time toxicity. Basically, visits to clinic that don't add that much benefit in terms of how long they live or how good they feel. And so the Perseus study, we were just talking about how wonderful it was, right? That was a study that just got published showing a phase 3 big multinational study done mainly in Europe, showing that adding Darzalex, daratumumab seems to help. That seems to definitely help in terms of efficacy. It was far from a perfect trial. I think Dr. Gurbakhash and I have many bones to pick with it because our research is how do we actually take those trial regimens and actually make them work better for patients. In that trial, they dosed bortezomib or Velcade twice per week, which is one of Dr. Kaur's and my core research areas. That has been shown to give people more neuropathy, more nerve pain, but not add anything in terms of how long they live or how long they're in remission for, plus more time toxicity, more time in clinic. The Perseus study actually also used dexamethasone daily for 4 days in a row, so not once a week, the way that we typically do it in the US. And that's something that we're working on improving with a lot of our other research. And just to say, all of you who are listening to this probably have been on dexamethasone one way or there. in the modern era, probably one of the biggest things I do once patients are in remission is I, drop the decks. Any way possible, I say, look, in the era of daratumumab and isatuximab and carfilzomib and CAR-T and bispecifics, the oldest drug that has probably the least mileage that it's adding, but the most toxicity that it's causing is 100% those 5 pills a week or 10 pills a week of steroids, dexamethasone. So trying to improve that is better.
Right. We also have some more questions in the chat here. I'll speak about the next one. How do you inform your patients about these updates in myeloma treatment? What can they stay hopeful for in a positive and helpful way for them to understand?
I can take that one. This sort of live panel is a way to do that. We're very fortunate, that with the advent of social media and the internet, information is now available at patients' fingertips. I remember when I was a fellow, and it's not too long ago, we were still giving out a lot of handbooks about how the drugs were approved and dosing. And now there is actually, we have very important organizations such as the Multiple Myeloma Research Foundation, the International Myeloma Foundation, you have HealthTree, and then of course, Oncology Data Advisor, and all these platforms to disseminate the information. Over the weekend, I gave a talk to a patient family seminar in Boca Raton that was held by the IMF, where we disseminated this information. There's a lot of concerted efforts to get this information in the patient's hands, and then even on YouTube, sometimes, when I do patient education on CAR T cell therapy or therapies, like I spend my 20, 30 minutes, whatever I need to do in the clinic with them. And then I'm like, you know what, I need you to lull over this. So go to YouTube, type in X, Y, and Z, TITS organization, CAR T, and myeloma. And you're not getting just information from Dr. Google. You're getting information in those videos, such as these. These are going to be available online somewhere, where the specialists who are informing you and giving you the knowledge are people who are actually treating the disease on a daily basis. So there's actually a lot of good and practical resources out there, this being one of them.
I completely agree. I'll echo that entirely. International Myeloma Foundation has been helpful. We have been trying, actually through the IMF, to partner, in Seattle, for example, we have the Myeloma Fighters, they're called. It's mmfighters.com. So I tell my patients, not MMAfighters.com, that's mixed martial arts, but mmfighters.com, and they're great. And our faculty, we give them, talks by Zoom once a month, talking about updates in ASH, updates in MRD, updates in this. And I think I have actually learned a lot. I mean, even the Dr. Gurbakhash is alluding to, I gave the same talk in San Diego, and I learned some tips from patients in that area about how they manage dexamethasone side effects, and that's helpful. To the second question, pivoting, just the question for those listening just to the audio of this was, is there any paper you can point to with any information on retrying daratumumab or on patients not becoming refractory to daratumumab? And it's tricky because a lot of the clinical trials haven't done this. Many of the trials of daratumumab or Darzalex Faspro prohibited prior exposure to the drug. In real life, we do it all the time. My style, and Gurbakhash will probably have something similar but her own flavor, because it depends, even within our group, it depends. Typically 6 to 12 months is what I would say is a pause that's sufficient to retrial it. The idea being is that protein that the daratumumab targets, called CD38, is kind of a core protein to myeloma cell growth. So if you give it enough time off the therapy, the myeloma cells that express that start to be the ones that start to grow again, and then thereby become susceptible to being targeted again. Typically, Dr. Kaur said I would try to do it combined with something different. So I wouldn't combine the exact same drugs again, perhaps keep the daratumumab or use the isatuximab Sarclisa that Alankrita just mentioned. Not huge evidence for that if there's a pause in between, but I think it's reasonable with something else. There are data actually that just going from, because as all of you know, daratumumab typically becomes once a month over the long haul. Isatuximab becomes once every 2 weeks. There have been some posters at previous ASH meetings talking about quote unquote reloading the patient. So giving them back the once a week dara combined with something else. And that's often enough to kind of put the myeloma back temporarily on the path towards remission. That's not a durable solution by itself, but it's something. And it proves that, the dosing matters and time matters. Some centers, and I don't do this, Gurbakhash, I'd love to hear if any of your centers do this, will look at a bone marrow biopsy and look at CD38 expression on the cells by flow cytometry. Flow cytometry is a particular test that looks at the outside of cells and seeing what they express. Most centers are able to stain or look for CD38 as one of the gates on that test, which is the marker that daratumumab uses. It's not that simple. In the initial studies, daratumumab, it actually didn't matter how much CD38 was on the cells or not. So I don't typically tend to use that as a barometer, meaning that if it's been a year, for example, since their last exposure to that particular drug, I would be very inclined to reuse it again with a different partner agent, with or without doing a bone marrow biopsy or looking at what it showed. That might be curious. I don't know if any of you look at CD38 by flow to tell you whether someone should get the drug again or not.
Actually, I don't. I've heard this for the first time. It sounds very interesting and theoretical, but I guess, what the understanding has been over the years is that it's not just the CD38 expression at that time, but eventually there's clonal tiding that can happen, and the CD38 positive cells, as Rahul just mentioned, the CD38 is really important for the cells to proliferate, and eventually the cells that have CD38 are going to outgrow the ones that do not have it. Or they can be, the receptors could also on the original cells upregulate as well with time. So have not really heard of that flow cytometry, but would love to, just for theoretical purposes and for the, just to see scientific excitement, I would like to see what the results would show with that.
Yeah, I mean, I'll just add, and I forgot to even mention the paper I put in the link. So the other test that we don't have now, but might be available in the future, and patients have asked for this, is ex vivo drug sensitivity testing, which is a mouthful to put. I'm sure that could take up a whole row of a Scrabble board there. The idea is that drug sensitivity testing, actually testing whether a drug works against the myeloma cells, doing an ex vivo. So kind of doing the experiment outside of the patient using their myeloma cells and then going from there. And so that actually showed that was a better, and this was a group research done by the University of Colorado. Dr. Shrebanow was the lead author, and that assay is not commercially available. We don't know enough about it, so what I'm not saying is that we should use that for everything we do in life. But I hope that in the future, as they've practiced using it more, as they make it available at more centers, that style of testing, that would be really interesting. Because at the end of the day, saying, oh, we should wait 6 months or wait 12 months, a little bit arbitrary, because everyone's pace of disease is different, everyone's myeloma is different. Potentially there may be a time where we can say, look, based on the bone marrow biopsy, I can tell you this drug, this drug, this drug, this drug, and this drug will work. We're done. That's wonderful. We are not there yet, but hopefully someday we will be.
So I wanted to add to that. That also requires one to get a routine bone marrow. Not everybody who relapses is able to get a bone marrow. And there's logistical patient preferences because those are painful. And so I think, and then flow often underestimates the population of plasma cells as well, depending on how sensitive your, everything is. So I think that is to be kept in mind. And we, at UT, we have one of my colleagues, he's a basic researcher. His name is Dr. Karim Azab. He has a 3D bone marrow model where actually, we've submitted grants where we're trying to combine 3 or 4, the same drugs that we're doing in clinical practice. We want to take a patient's bone marrow and then put it into this bone marrow, and then add the drug to it and see what the response ends up being and how the disease ends up being eradicated. But oftentimes there's a big gap, irrespective that you can do these clinical trials in the lab and they look so exciting, but there's like a big stretch in how it sort of gets translated into practice, right? But these are all cool and novel ways to see how can we make medicine very personalized, and or especially myeloma care, because a lot of treatments already have become very personalized. So we're sort of going towards that. I guess there's another question actually from Kathy Vida.
Yeah. So actually, I think this is a great opportunity to talk about transplant and, how we assess eligibility. I know Rahul talked about dynamic frailty, and by giving people more of these frontline treatments, more of them actually, are eligible for transplant with their treatment, even if they were not at the time they first presented. So is transplant still the best treatment for multiple myeloma? What do you all think? Would love to hear your opinions, because I think it's who you ask about this these days.
Are you talking to a transplanter or a non-transplanter? I think that's a prerequisite to start this conversation. I do transplant, I do CAR T, I do start to finish of myeloma therapy. And I think at the present, I still do transplant. We have seen that over time, the transplant utilization has become less, and there's so many factors that go in, right? The patient's age, the dynamic frailty is definitely an aspect of it. What are the quality of life? What are the patient's preferences? What kind of support system there's? There are these markers that are independent of disease that sort of tell us whether we should do transplant or not and what the patient prefers. But in my book, someone who has high risk disease, which is those genetic mutations that the bone marrow has in the myeloma cells that tell you what's your risk status. And if doctor doesn't disclose them to you, you should always ask them about it. So high risk status. And then we have this phrase called functional high risk. And Rahul, you and I have sort of talked about this very often, right? The patients who really don't have these high risk genetic features of their myeloma, but just, are relapsing very quickly or are not exhibiting a deep response to the 4 drugs or the 3 drugs that we're giving. And there's, so those patients, the high risk patients, no doubt, if they are physically capable, if they have good heart function, good kidney function, well, irrespective of kidney function, because even we take dialysis patients to transplant, I very much advocate for a stem cell transplant. If someone is younger, the disease is standard risk, and the patient wants to defer, then I leave it up to the patient and we discuss the data. Ultimately, it's a patient-doctor, it's a patient-centered discussion that happens, but you discuss the data about the determination trial, right? Which is a trial where patients one group got RVD, Revlimid, Velcade, and dexamethasone. The other group got Revlimid, Velcade, and dexamethasone. But then one group got stem cell transplant right after, and the second group got more RVD, followed by Revlimid maintenance. And what it showed was that the patients who had upfront transplant had a longer remission time, by almost 20 months. But in the end, the survival was the same. So that information really helps patients make a decision about whether or not they want to do transplant. Now, some patients may want to do it, but they may not want to do it now. And they have to remember that if you want to do it, 20% of patients end up having some sort of complication or toxicity from their myeloma or from their disease treatments that they get. They end up not becoming transplant eligible later on. So that's a key point to take on. But the determination trial sort of helps us guide our patients when it comes to the transplant discussion. I very much still do it. I think there's a second part of that question, which is cardiac amyloidosis. And for cardiac amyloidosis, it's a very complex discussion. I think beyond the scope of our talk, we can even briefly go into it, but that's a very nuanced discussion because patients, individual cardiac biomarkers, so many other factors, what their responses to their prior therapy is, that sort of drives the discussion. So I think that's beyond the scope of it. So maybe we can sort of dedicate another patient webinar to talking about amyloidosis. But for now, just focus on this, if that's okay with y'all.
I think another thing we often overlook with transplant too is really what patients have to go through to even get to the part of transplant. So in general, with treatment for myeloma, there's induction, consolidation, and while you're planning consolidation, you're getting everything ready for transplant. So most myeloma patients have to see 2 different oncologists. One that's a transplant specialist and one that's their oncologist that's been giving chemotherapy for the myeloma. And at the same time, when you're getting ready for transplant, these patients often are hospitalized for up to 2 to 4 weeks, depending on how aggressive a center is. And then even after that, because they get such high intensity chemotherapy, based on the type of transplant they get for 3 to 6 months after, they're really isolated. Often patients aren't able to work unless they're working from home too, because they can't go outside and would require frequent weekly visits with their centers. So like transplant often has like a ton of great benefits for patients in terms of improved survival in some populations and keeping the disease under better control in most populations. But when you're also thinking about, can your patient physically get to a transplant center? Unfortunately, not every patient in this country lives that close to one to be able to do these. And they do often have to uproot their lives, move for 3 to 6 months. And if there's any complications, even longer too.
Agreed. And so the last thing I'll say, because I know we should probably pivot to the relapse refractory setting shortly, but I always tell patients that I hope every time I give a talk like this a year from now, it's out of date. And so part of this stuff will already be out of date next year. But briefly, there are studies, because everyone's going to talk about CAR T. We're about to start talking about CAR T in this webinar. But there is a study that is just activated, I think, in Europe, already starting to accrue. And yeah, Gurbakhash nodding, you might have it there too. Eventually, CARTITUDE-6. That's looking at CAR T versus transplant in patients who get a quadruplet induction. And so in 2035, ask us when that study is fully read out, hopefully earlier than maybe like 2030 for like MRD or some of the preliminary endpoints, but we'll know then. But I think that'll be a really interesting study to see in the modern era, where does transplant truly fit, with a quadruplet induction and with CAR T being the competitor, so to speak. But we'll see. Until then, I would still offer transplant to everybody, and then it's a values discussion for all the reasons that everyone just talked about.
Sounds great. Just I think just a couple more points that we can briefly talk about is apart from this specific regimen that we were talking about, DARA RVD as per the Perseus trial, there are also other quadruplet regimens, such as the ones studied in the ISKIA trial with isatuximab, carfilzomib. And which patients would you consider for one or either of these?
So what I tell community doctors is I don't care which quadruplet it is, as long as it's a quadruplet, is the short answer to it. I think a lot of patients agonize over, should I get DARA VRD or DARA KRD, or Kaiser's offering ISA VRD, should I do that or ISA KRD? I would say 4 drugs. I will say starting with 4 drugs doesn't mean you're legally obligated to finish with 4 drugs. Most of my patients end up on 2 or 3 or dose reductions or etc. In general, carfilzomib, so DARA KRD or ISA KRD, I tend to use for patients, or consider it in patients who have 1 or 2 high-risk features, typically 2+ high-risk features. Isatuximab is not yet routinely used or approved for frontline therapy in the US. Some insurance companies like Kaiser can do it. So in terms of DARA versus ISA, I wouldn't sweat that in the frontline setting. There's a bortezomib versus carfilzomib. For boards, we teach the medical students that bortezomib or Velcade causes neuropathy, carfilzomib or Kyprolis causes heart issues. In real life, it's much more complicated than that. Depends on the dosing, like we talked about, once weekly, twice weekly. Depends on the dosing of the carfilzomib. Is it the full dose or is it a partial dose? Giving lots of fluids. Do they have a cardiologist? Do they not? So I tend to talk about both. However, this is going to be a topic for another day. I know of centers in New York, for example, like Memorial Sloan Kettering has moved, if I recall correctly, to DARA KRD for almost everyone, regardless of cytogenetic risk. I'm doing it more for the 2+ high-risk patients based on a study called the MASTER study. Slightly beyond the scope of this, because I know we need to pivot. I don't know, Gurbakhash, any thoughts on that?
No, I think you guys have mentioned all the appropriate points. The only thing is keep in mind that every center, or whether it's an oncology practice or cancer center, they have something called formularies, and there's P&T committees, and they sort of go through the financial aspect of which drug is more feasible. That's just a reality of what we have to deal with, right? So many may want to do isatuximab, but their formulary only carries daratumumab, and vice versa. So that also plays a role in the back end of how this ends up being chosen. But we can pivot to the next topic.
All right. So, a lot of patients, as per the Perseus trial, patients were actually getting DARA and Revlimid in the maintenance after transplant and consolidation. And 64% of them, I believe, were able to come off the daratumumab based on MRD negativity. So I think that is something new and exciting in terms of maintenance therapies for myeloma patients. Historically, they've always been on treatment with maintenance. And, with the MRD testing, we're at least able to de-escalate some of these in trials. What is your practice regarding the use of MRD testing or maintenance therapies?
So I can go first. I only reserve doublet maintenance, which means 2 drug combinations for high-risk patients. And generally, even if I do a quadruplet, which is the 4-drug regimen for induction, I will mostly do lenalidomide or Revlimid for maintenance. And if somebody has a deletion 17p or those genetic markers that we talked about, then I would do a doublet or a 2-drug combination, whether it's DARA Revlimid or a proteasome inhibitor, whether it's Velcade or a Revlimid. And the factors that help decide which one you end up choosing really is history of cardiac disease or neuropathy and what their exposure was. So generally, it's a 1 drug for standard risk patients.
I would agree. And I think for the topic of MRD guided discontinuation, to be fair, in Perseus, they would go from Dara-Len to just Len maintenance for the long haul. I think that is still the US standard of care, lenalidomide, until progressive disease or intolerable toxicity. But again, ask us again in a year. And hopefully next year, as studies like MASTER and MASTER-2, which are other studies that have, and there's another study called the Dramatic, a cooperative group study, SWOG 1803, that are looking at this. Every year, we'll get more and more information about who are our patients and whom we can stop based on MRD, what threshold do we use, how long do we wait, and so forth. So more to come on this.
So I guess so far what we've really talked about is when a patient's newly diagnosed with multiple myeloma, but unfortunately so far myeloma does have multiple episodes of relapse. And while we have different drugs to treat each of the relapses, there have been a couple of new drugs that are FDA approved and like in the past for like much further down the line, but just because they've been blowing everything out of the water, we've been bringing them more upfront. So two of them are basically CAR T cells. So one's ide-cel, the other cilta-cel. And then we now also have a ton of new bites and specifics, which I think maybe we can start talking about those therapies too for myeloma. So just with the KarMMa trials and the CARTITUDE, how have you guys started incorporating that into your practice for patients?
I was going to say before we go into that, let's, what is CAR T cell therapy and bispecific therapy? We should sort of spend a few minutes on that. I can do that. So CAR T cell therapy is basically where you take the patient's T cells, you take them out, you get hooked up to a machine, they get collected, and then they're sent to a lab. In the lab, the cells are basically retrained to think of myeloma as a foreign entity and say, this is foreign, you got to go back in the body and kill it. If you see cancer myeloma cells, you got to do your job. And that's exactly what happens. That retraining or re-engineering time takes about 4 to 6 weeks at minimum. It could be longer based on the current products we have. Then those stem cells are, those CAR T cells are reinfused into the patient, and that requires a 7 to 14-day hospitalization or outpatient where patients are very closely monitored for toxicity. So, but it's a big gun, one and done kind of an approach where you're harnessing the power of the immune system. Bi therapy or bispecific therapy, in other words, T cell engager therapy, is where you say the myeloma cell and the T cell, the T cell's kind of shy, hiding out in the back end. And then the BiTE comes in and says, hey, I'm going to play matchmaker. I'm going to hook onto the T cell and I'm going to hook onto the myeloma cell and bring them close together. And when they come, what happens? The T cell is recognizing, oops, this is a foreign entity. I got to do something about it. And then the T cell goes and targets the myeloma cell. But the BiTE therapy has to be given on a weekly or every other week. And even there's some in clinical trials where they're being given on a monthly basis. So the difference is CAR T cell therapy, they're both very effective therapies. In an era where patients, if you take a single myeloma drug, whether it's Pomalyst, whether it's belantamab, the response rates in the single agent was usually about 20 to 30%. And now we have CAR T cell therapy and BiTE therapy, and the responses when patients get given these therapies is about how much? I would say 70 to 90%. And sometimes, and very deep and durable remission. So patients get into remission and they stay into remission. So that sort of has revolutionized, as Richard was saying, revolutionized what we as myeloma specialists do. So obviously, so I just, I've sort of given this background, and I'll turn it over to Rahul. Maybe he wants to talk about how he incorporates these agents.
That was an excellent introduction. Thank you, Gurbakhash, and I agree. And I think the tricky part is, as I think it was, I forgot, either Richa or Alankrita had mentioned earlier, that a lot of times by historically, all of our newer treatments get saved for later lines of therapy. That's just how clinical trials are designed, and now they're slowly being moved up into earlier lines. And so as of right now, March 18th, 2024, and probably the entirety of this month in the US, CAR T will only be approved, bispecifics will only be approved for patients who've had 4 or more prior lines of therapy. A line of therapy is itself a dated term referring to kind of a treatment not working because the myeloma starts to relapse or patients have toxicities from it. That may change. So just last Friday, for example, so even newer than ASH, the FDA's advisory committee, something called an ODAC, met to discuss 2 trials that had just moving CAR T into earlier lines. Either in one of the studies, 2 prior lines of therapy with a drug called ide-cel or Abecma, and in one of the studies, just 1 prior line, even at first relapse, with a drug called cilta-cel or Carvykti. And in both cases, the advisory committee recommended moving these drugs into earlier settings. So it still needs to be approved by the FDA and then employed into, as Gurbakhash alluded to, insurance formularies and so forth, but it's coming. And I think it's very likely that by this time next year, CAR-T will routinely be available in earlier lines of therapy. So as of right now, I'm going by the book. And so we have to, because insurance won't pay for it otherwise, and say, look, get to 4 prior lines of therapy, and only then are you candidate for CAR-T or bispecifics. It's tricky because in real life, for most patients, once 3 lines of therapy have stopped working for the patient, that 4th line is not really doing much. It's just checking off a box in my mind. And so I'm actually very grateful that if CAR-T is moved up, it'll put the decision-making back into my hands with my patients in front of me and not the insurance company dictating who's able to get what. They will still certainly try, no doubt about that. But what I would say is, as of now, as soon as someone's had their first relapse, I start thinking about how might CAR-T fit into their future, because one could argue that for someone who may get CAR-T in the future, a drug like bendamustine, certain chemotherapy drugs might actually make CAR-T cell not work as well. Dr. Kaur had alluded to the fact that, as of now, our approved CAR-T cells require the patient's own immune cells to be collected, and certain chemotherapy drugs like bendamustine tend to interfere with that. There's a theoretical risk that if someone is on a bispecific antibody like teclistamab, talquetamab, elranatamab for a long time, and then you try to collect your T cells for CAR-T, those T cells might get exhausted from the continued redirection that the bispecific antibody has led to them. So if someone has CAR-T in their future, I might try to avoid that and try to sequence, quote unquote, the CAR-T before relying to bispecifics. Real life is not so simple, and some patients cannot get CAR-T, or it's not safe for them to get CAR-T. And in those cases, bispecifics are an excellent option. So I think my bottom line as of now is I tend to try to get patients to CAR-T if I can, just clinically, logistically, safety-wise for the patient rather than bispecifics. However, bispecifics are super important if CAR-T is not an option or doesn't work or patients can't get to CAR-T. Right now, as soon as someone's had their first relapse, I start thinking about it. As soon as they've had 3 prior lines, I definitely start planning for CAR-T by default, is because the 4th line is not going to work no matter what it is. And hopefully a year, if not 6 months from now, CAR-T will be approved in earlier lines. And then probably my sweet spot would be that 3rd or 4th line of therapy probably should be CAR-T. 2nd line is controversial because I think there are a lot of good 2nd line treatments out there. A lot of my patients for CAR-T, as Richa alluded to, have to move and relocate to get here. And so if my patient has to choose between CAR-T and 6 months, 3 months of their life being uprooted, moving to the big city versus daratumumab, carfilzomib dex, or isatuximab carfilzomib dex, where they are with their primary oncologist and get equal amount of mileage, I would say, don't come here. Keep doing what you're doing and come find me afterwards.
I think those are all really good points, and it's so interesting to see how like insurance really plays a big role in what we're able to give to our patients too. Do you typically, when patients have relapse after CAR-T, do you still consider switching the different CAR agents, or do you think that you need to go back to other chemotherapy, like more traditional chemotherapy agents?
That is an excellent question. First of all, no insurance company is going to pay us to do another CAR-T, especially if it's the same target. And right now, the only target we have is BCMA. You're right. A lot of our life revolves around insurance companies and begging them to give approved therapies for our patients. So we end up not utilizing that because of the financial and the insurance issues. And the second thing is, if you do relapse after CAR-T, there's this thing that maybe the T cells are exhausted and you want to sort of reinvigorate them. There's actually clinical trials that are in development for giving some sort of immune awakening kind of medications to do that. And one of those medications is actually what patients are already taking, such as the IMiDs, the immunomodulatory agents. So I believe one of my colleagues, the City of Hope, is going to have a trial where patients get ide-cel. And post ide-cel, they may continue on mezigdomide, which is one of the CELMods. It's not a drug that's approved yet, but it's in clinical trials to keep the T cells activated so they don't lose their response. Another trial that's in development already, it's going to it's going to go onto the floor, and actually we're going to participate as a center. It's an investigator-initiated trial. Is to give something called PD-1, such something like nivolumab, after I believe if you achieve a partial response or something of that nature. Don't remember all the details. So there are strategies that are in development right now. They're looking at how do you keep those T cells reinvigorated. That's one. The other thing is, how do you sort of sequence? Because once you've got in CAR T, that's fifth line. What's beyond that? And how do you sequence the immunotherapies we have between the BiTE specifics and CAR T cell? And like Dr. Banerjee earlier said, Rahul said that, maybe you don't want to do the BiTEs before the CAR T cell, but in our clinical practice, when we don't have options, I've given both teclistamab as talquetamab post CAR T failure, and particularly teclistamab, even though it targets the same thing, which is BCMA on the myeloma cells, and we're still able to have deep and durable responses. So there's a lot of research going on into that space as well, because I don't think we have the exact answer. So I think we'll get more information on time as goes along. And then obviously clinical trial participation, I recommend it to all patients, and that's what helps us, get these therapies approved for all patients. So I try different approaches in this space in order to capture the responses. I don't know what Rahul thinks, and he can add on.
Not much to add there. That was excellently stated. Yeah. Again, same principle going back to that every year this talk will be a little bit irrelevant bit by bit. But yeah, I think probably there will, I think Alankrita, you alluded to this earlier in terms of sequencing. There may very well come a time when we use CAR T second line for almost everybody 20 years from now, and some of these older drugs are coming out after CAR T failure. So the whole cart gets put before the horse. I guess that's a pun. CAR T gets put before the horse of everything else beforehand. But the time will tell, and I think that will be really interesting. The other part that we haven't really talked about would be kind of precision diagnostics. Gurbakhash briefly alluded to the functional high risk, and I know Ankita put that note in the chat that, unfortunately, we can't always tell who are those patients who need more aggressive therapy or need more, 2-drug maintenance and not one. We kind of wing it. For patients who have high risk cytogenetic, we typically use 2, if not 3 drugs for maintenance versus not. Many of these patients with functional high risk who have an early relapse have standard risk cytogenetics, and I've had patients, I'm sure Gurbakhash as well, who have deletion 17p, but they are in remission for years and years. And so those, diagnostic criteria are not destiny, and we need better tools to understand, who needs that extra layer of support versus in whom can we de-escalate therapy, and how can we catch relapses earlier. We didn't really talk about imaging, but for example, one of my takeaways from these last couple of ASHs has been that whole body MRIs. So MRIs focus on the bone marrow, often can pick very subtle lesions within the bone marrow before the myeloma cells start chewing into the bones around them. And potentially, actually, there's a study going by Dr. Mohyuddin at the University of Utah looking at smoldering myeloma using MRIs, and not treating those patients, seeing what happens. And it may be that if we are able to find a smarter, I don't want to say more intensive monitoring, because for a lot of patients, a lot of time toxicity that comes from an MRI and extra lab work and soluble BCMA, but there may be a way in the future for us to kind of tailor our intensity of monitoring to catch the relapses like that when they happen and give therapies like that when they're needed and not when they're not needed. We have about 3 minutes left, so I can ask Kiera, do you know if there are any other comments in the chat right now or questions?
Nope, no other comments right now.
Maybe we can just go around to end and say one cool abstract or parting words of advice from ASH for patients, or just feed guidance for patients with myeloma. I will let Gurbakhash, you go first, and then we can go back around and I can go.
I think, everything that's coming out is quite exciting. Sometimes we're overdoing it, sometimes we're underdoing it. But the goal is that, I don't know what I'm saying, but the point is that, we're very fortunate to be in this era when there's so much remarkable discovery happening. And as a patient, just keep on advocating for yourself, because you're your best advocate, and seeking a second opinion or seeking extra information from other colleagues or people, that's the best way to go about it. And, hopefully we'll have better therapies with less toxicity in the future.
Okay. Richa, you want to go next in reverse order, and then I can round it out?
Okay. So I guess my parting advice for patients would be, so many of the abstracts at ASH this year were really focused on side effect and toxicity profile for patients. And oftentimes patients aren't very vocal with what side effects they're having. And there's so many different ways, especially as a palliativist. I love treating these side effects all the time. So please like bring these up with your oncologist too, because you can always do dose reductions for your chemotherapy. You can always add a secondary medicine to address pain. But the thing is, it's patients with uncontrolled symptoms do worse than if your symptoms are better controlled. And it also helps us as oncologists take care of you better. So don't ever hide your side effects.
Excellent. Alankrita?
So I actually wanted to talk about lifestyle medicine and how it's also integrating in the care of our myeloma patients. Particularly, a lot of my mentors are working in the fields of exercise and plant-based diets, etc., that can, improve the T-cell exhaustion. So, the T-cell exhaustion is the big problem with CAR-Ts and things like that. So, just I know it's basic information and something, grandmothers tell us to just eat good food and exercise and, stay healthy. So we should not undermine the benefits of those as well.
This is excellent. These are all excellent points. And then I would add something I think that Gurbakhash had mentioned earlier is that, and I think it might not be a problem for anyone listening to this because you are clearly a very empowered patient, but also I think seeking guidance from other patients and patient support groups. I cannot understate enough how important that's been for many of my patients. Many of them are pretty reluctant. Some of you listening to this may be reluctant to say, oh, I don't want to Zoom with other patients with this because everyone's case is different. And I agree with that. But I also have found that it's very helpful for patients to learn from each other stuff that I couldn't tell them. Like it's one thing, like I could talk about CAR-T and bispecifics, but the details of lenalidomide funding mechanisms and which grant to use for and how to pay for this and which resources, things like that, patients are excellent. And I would say that the IMF has groups that they can organize or virtual support groups or Facebook groups. Obviously a lot of misinformation on the internet, but I think having that community I think is important because multiple myeloma is not a rare cancer by any means, and it's getting more and more common, I think, as people are getting older and more detection is happening. So a lot of work left to be done, but I think having patients as your advocates is really nice. So with that in mind, maybe I can close things out then. So I will say thank you all for Dr. Thakur, Dr. Taneja, Dr. Kaur for speaking here. Thank you, Kira, for organizing this. Thank you all for listening. I think myeloma, it's historically been called Myeloma Awareness Month. The IMF has tried to change that to Myeloma Action Month, and I love that. I think hopefully all of you have learned or heard about different tools that we're talking about, ways to take action with your own health, whether it be lifestyle interventions, better talking about your toxicities, getting a second opinion at an academic center, or having a patient support group, or any combination thereof. I think is a great way to help help people live with myeloma for better and for longer. So with that, I'll thank you all for your time. Have a good afternoon.
Amazing. Thank you all so much. And thank you again to the audience for watching and for submitting such thoughtful questions. I'm glad we were able to answer these, and thank you all for such insightful answers to them. So thank you again to everybody for watching, and I hope you have a great rest of the night.
Thank you all. Yep. Bye-bye.